Thanks. Thank you very much, Mr. Chairman, and thanks again for inviting me to talk. I was given this task to talk about acute heart failure and the epidemiology, precipitating factors and management. So I'll do my best because it's a slightly vague subject, actually. It's two main types of heart failure we're talking about. One is what we call de novo, i.e. it's the first time it comes out of the blue. And the more common, actually, is probably people who are relapsing. They're known to have heart failure, and then something happens and they get worse and they get admitted again with heart failure. And that's called acute decompensated heart failure. But usually we just talk about people with acute heart failure, or acute on chronic was the old term. And by acuteness, we mean short, basically, not severe. And that can vary from a few weeks to a few hours or minutes. And you do see occasionally people who do go into acute pulmonary edema incredibly fast, or so-called flash pulmonary edema. And basically anything wrong with your heart can cause it to go into acute heart failure. So there are lots of causes. And often there is a clear precipitating factor or trigger, which I'll talk about in a minute. And the presentation, again, can vary, as I say, from life-threatening pulmonary edema, which can really kill somebody remarkably quickly, to a more slow onset with a progression to cardiogenic shock. And some people just come in with worsening severe peripheral edema and pulmonary edema as well. It varies a lot in the balance between how much is left and how much is right heart failure. Some people with severe right heart failure just present mainly with peripheral edema and ascites and not very much pulmonary edema. So now this is some data. This is from the US, which is kind of semi-relevant, but it gives some idea of the rise in hospital discharges for heart failure over the last 20 years or 30 years. And you can see that it's been steadily rising, but it looks like there may be a little bit of a plateau beginning around about 2005. I'm not quite sure why that is, but it may be that the treatment of chronic heart failure has got better, so that the fewer patients are getting readmitted. But you can compare that to coronary artery disease, which actually has shown quite a marked fall. So perhaps more of these patients, as we have mentioned many times before, with coronary disease surviving now, but with damaged hearts, and therefore go on to develop heart failure. And this is some data about the age distribution, which I think we're all well aware of, that it's predominantly a problem much more in older patients, but that varies where you live, which I'll talk about in a minute. Recently there's been published this quite nice big review, which is particularly relevant to our society, about heart failure in the low and middle income countries. And they basically looked at every single publication they could find from these countries on heart failure. And I'll just review a few points about what they found. These are basically the countries which they looked at, the papers. These are what are labeled as middle and low income countries, though some are changing quite quickly. For instance, China is, as we know, getting rich very quickly. So that may be in a different category soon. This is quite interesting, really. It shows the age of onset of heart failure against what's called the Human Development Index, which is an index which the United Nations have which is a measure of wealth, basically, of a country and education levels. And I think this has been apparent over the last few days. Many presentations have noted the lower age of presentation in certain countries from this area and other areas, like Africa particularly. There was a paper presented about African heart failure, the much lower age, about sort of 10 or 15 years younger. Interestingly, data from Korea, patients were much older, and most patients in sort of more wealthy countries are in their 70s to 80s. This is looking at etiology, and we can see here this is the main cause is considered to be ischemic heart disease. And I hope you can see this. It's not easy. Here's Africa this is I can't read it myself actually, Americas, Eastern Mediterranean, Europe, this is basically Eastern Europe, Southeast Asia, and Western Pacific countries, which is basically, they call China. Is that right? I can't read. It's China, yes. Anyway, you can see here what we already know, really, that ischemic heart disease is not such a big problem yet in Africa. It is in most of the Americas. It's quite a big problem in what we call Eastern Mediterranean, Egypt, etc. And I think that's obviously apparent in this community, that coronary heart disease is on the rise. And in Eastern Europe, coronary heart disease is a big problem. So, of course, the opposite of that is hypertension, where we know that hypertension is the main cause in African countries. There are some American countries here where hypertension seems to be quite a big problem, and you can see it's less of a problem in these Asian countries and Eastern European countries. Cardiomyopathy is something which is a cause of acute and chronic heart failure, something which we don't often mention very often well, certainly not in this meeting, but it's actually around. And many patients with dilated cardiomyopathy present quite acutely. And I can tell you an anecdote. When I was working in Birmingham, we had a patient transferred. Birmingham was a liver and a cardiac transplant centre. We had a patient transferred from a peripheral hospital for a liver transplant. And he had severe liver failure. But no one had actually bothered to examine his heart, or in particular look at his JVP. And they did a liver ultrasound. It showed a congested liver. And then somebody decided to do a cardiac ultrasound, and it showed a really severe cardiomyopathy. And when you talked to the patient, it was quite clear his symptoms were originally breathlessness, which he'd been having for that previous 3 or 4 weeks. And it turned out basically he had presumably an acute myocarditis and a severe dilated cardiomyopathy with severe right heart failure followed by liver failure. And there was a lot of debate about whether he then also went into renal failure. So we were trying to tee him up for a joint cardiac and renal transplant, but unfortunately he died before we could get it. So the cardiomyopathy patients are still around, and I don't know, I'm interested to know whether in this community you find many patients with dilated cardiomyopathy. It's partly genetic, as we know, there's a very strong genetic influence, and that may vary between different communities. Valvular heart disease is still around. Of course, the rheumatic mitral and aortic valve disease is disappearing everywhere in the world, but it's still present in Africa a bit. But I'm sure it's going down there. But coming through, of course, is all the more chronic valve disease. Aortic stenosis particularly often presents with acute heart failure. Undiagnosed aortic stenosis is very common in 80-year-olds that present with heart failure. And I think that's one of the main reasons for doing an echo on every single patient that comes in with acute heart failure, because you cannot diagnose very severe aortic stenosis in someone in heart failure. It's a very difficult diagnosis because the pulse is very small volume, which could be due to the heart failure, and the murmur is very short. It's not a particularly loud murmur sometimes when the left ventricle is failing. So aortic stenosis should not be missed, because whatever state the left ventricle is in, it's nearly always worth replacing the aortic valve. And now you can even do that, arterial replacements rather than cardiac surgery. But I've seen patients with terrible left ventricles with aortic stenosis, the valve's been replaced, and they do very well. So it's a very good reason for always doing an echocardiogram on anybody with acute heart failure. Now there is some local, paper was referred to a couple of days ago, which is a registry which has started in Saudi Arabia. And just to give you a quick summary of what they found locally here, there's over 1,000 patients who were admitted into hospital. The majority, 66%, were admitted with acute heart failure, and this is chronic heart failure, HCHF. The age is younger, 60 years, although Saudi Arabia is an incredibly rich country. So I don't know, maybe this is a slightly anomaly. But over half were completely new heart failures, very high level of diabetes, which I think probably is a problem in this community, the high level of diabetes. It's also an increasing problem in Asia. 70% had severe left ventricular systolic function, which is slightly different from other areas of the world, and over half had coronary artery disease. And mostly were treated according to guidelines. At least they got beta blockers and ACIs. And the patients with chronic heart failure had a similar profile. In-hospital mortality was 5.3% and 7.5% after discharge. So relatively high mortality, but not unusual. Now, one of the things you saw in that study that locally, it seemed to be mainly patients with systolic heart failure. But this is actually some data from the US, and their data shows that about half the patients actually have what we call heart failure with a preserved or normal ejection fraction. And here's some data of the acute heart failure of the big trials which have been published, and the Adhere trial is here as well, which is the one which is basically acute heart failure registry. And you can see here that the age, of course, as I said, is about the 70s in the US, but younger here, about a very variation on gender between the different types of preserved ejection fraction, and there's a slight predominance more of women in the preserved. Hypertension, again, it comes up as more common in the preserved than the reduced, but it's not highly significant. And coronary disease is again more common with reduced and preserved. Diabetes is about 30-40% in this community compared to 60% in Saudi Arabia. And peripheral edema, of course, is quite common. So it's not huge differences clinically, really. But this is quite an interesting little point they make about the difference in response to treatment. I'm not covering treatment today, but I thought it just a little vignette of the pathophysiology of HFpEF. And I think we should think about HFpEF as a disease of circulatory stiffness. Okay, the arteries are stiff, the heart's stiff, and actually probably the veins are stiff as well, but not many people have looked at the veins. So they have very high end systolic elastance. So the left ventricle is actually stiff in systole. And they also have high arterial stiffness. And when you treat them with vasodilators, they get a much bigger drop in blood pressure because the arteries and everything are very stiff. So when you dilate those arteries, the blood pressure drops a lot for the change in arterial elastance. The same change in arterial elastance almost, but a much bigger drop in blood pressure. So basically, if you're giving vasodilators for people with HFpEF, you want to be a bit more careful about the blood pressure because it may drop surprisingly quickly, much more quickly than you might anticipate. So that's some basic epidemiology, which I think a lot of it is pretty well known to all of you. Now, the initial assessment, monitoring the patients, there are three things you have to do, really, when you get a patient in. Is firstly, does the patient have heart failure? Now, often that's completely obvious, and they have all the typical signs, acute pulmonary edema, crepitations, and they look sick. And but you must be wary of other possible causes, particularly chronic lung disease. Sometimes people present with a lung cancer with a huge pulmonary effusion, pleural effusion, with right heart failure, which looks like heart failure. People with kidney failure often look like heart failure. And actually, the problem is compounded by the fact that heart failure with normal ejection fraction is actually common in people with renal failure, independent of the fact they may be volume overloaded, because they have hypertension, they have diabetes, they have the risk factors for HFpEF. And we've written a few, in collaboration with a nephrologist called Angela Wang, we wrote quite a lot of papers on this subject. Pulmonary embolism is the one which is often missed. They present sometimes just with acute, what looks like acute right heart failure. And they have a history of increasing breathlessness, but the characteristic thing is the chest X-ray is clear. There's no signs of pulmonary edema. So that's something always to look out for. I've seen patients admitted with acute so-called heart failure, breathless on exert, and they die 2 days later with massive saddle embolism. So it's something not to be missed, particularly obese patients. Middle-aged obese women are very prone to this in my experience. So if the patient does have heart failure, what's caused it? What's precipitated it? And does this require immediate treatment, i.e. an arrhythmia, or is there acute coronary syndrome? And beware of diabetics. They get acute coronary syndrome without any chest pain. They often just present with breathlessness. And that's another trap sometimes, to miss the acute ischemia. And then the next big question, does this patient need to be is this an ITU type of situation? Do they need ventilation, or particularly ventilation either as CPAP on the ward, or do they need to go to an ITU to be ventilated properly? Or are they a person who's heading for an LVAD or even transplant? So that's the clinical decisions you have to make. These are some kind of data on presenting profiles in emergency departments, people with acute heart failure. It's about a quarter actually due to hypertension, so they're predominantly just hypertensive heart failure. In others, the blood pressure is a bit elevated. Now, of course, as the heart fails, the blood pressure tends to come down. So you can be misled. Someone may have hypertensive heart failure, present with heart failure, but the blood pressure can be particularly normal. And I saw a lot of this in Nigeria when I was much younger. And we found a lot of patients presented with quite severe heart failure who were normotensive. But when you treated the blood pressure, once you treated the heart failure, the blood pressure began to creep back up as their heart recovered. And then you realize these actually were hypertensive patients. So a low or normal blood pressure doesn't rule out the fact that this may all be hypertension. Actually, a very low blood pressure, less than 90, is quite uncommon. Cardiogenic shock is also uncommon, usually less than 1%. Flash pulmonary edema is also quite uncommon, 3%. And acute coronary syndrome is about 25%. And 25% of patients with acute coronary syndrome have heart failure symptoms and signs. And as I said, if they're diabetic, they may have no complaints of chest pain at all. So it's something to think about in a diabetic patient. This is some more data on acute heart failure emergency presentations. This is some mortality figures. This is mainly from North America. You can see in-hospital mortality is 3 to 4%. And 2 days is acute coronary syndrome, and you can see here acute heart failure is much the same, but has a much higher mortality at 90 days, 60 to 90 days. So this is a problem with a lot of these patients. They get treated acutely, but then they don't really get looked after very well prior to discharge or after discharge, because they get into a different department, or they're under the general physicians and are not followed up. And we know a lot about how to treat ACS, but as we'll hear later, I'm sure, there's really very little data on how to treat acute heart failure. You would think by now acute heart failure is something that's been with us for centuries. And we still using the same treatment as diuretics because it works, but we have no data. And there's very little other useful treatment, it seems. So mostly the guideline data is what's called C, i.e. anecdotal, really. So precipitating factors, I think any clinician, any of you who are working in wards are well aware of all these things, particularly atrial fibrillation. Very common. As the pressures rise in the ventricle, the atrium works harder, and then eventually you get atrial failure, and finally atrial fibrillation, which then pushes the patient into heart failure. As I said, acute coronary ischemia, myocardial ischemia is often there, and may be made worse by the heart failure, because the rising wall stress increases the demand and increases the chances of inducing ischemia. Post-coronary syndrome, we're all well aware of this, a ruptured septum, mitral valve, chordae rupture, and right ventricular infarction are very common. We know the difference. Pulmonary edema doesn't occur usually with a VSD. You get right heart failure. Mitral valve, chordae rupture, you get extreme breathlessness with pulmonary edema. And right ventricular infarction is all right heart failure with clear lungs. So these are other things. Acute pulmonary embolism I mentioned. Cardiac tamponade is another one that's often missed. Looks like a big heart. Again, always do an echo. Aortic dissection. That's a very misleading one. Severe chest pain, it dissects back down into the aortic root, and you get a pericardial effusion. And they often present with breathlessness as well as chest pain. And peripartum cardiomyopathy is a very interesting condition. Presents usually within 6 weeks of delivering a baby. It's no one quite knows what the cause is, but it's maybe an autoimmune disease, it may be related to prolactin, and it's a very severe disease. It actually has quite a high mortality. My research project in northern Nigeria, the reason I went there was to study postpartum heart failure, because in northern Nigeria it's very common. And I met the professor of medicine there, and he said, we got this problem with heart failure, why didn't you come out for a year or so? And it was a terrific experience. I really enjoyed northern Nigeria in those days. And it turned out actually it was related much more to special postpartum procedures where they feed the mother a lot of salt and also keep her very hot. And it induces a kind of water fluid overload. And they get better very quickly. But that's different from true peripartum cardiomyopathy, which is worldwide. So less rapid deterioration is particularly infection. And one which is often missed and most worryingly is infective endocarditis. In the best centers in the world, infective endocarditis has a mortality of about 25%. So it's a disease, it's a killing disease, and it's one of those things in medicine should never be missed, like meningitis or a cerebral abscess, because they're treatable. So always think about endocarditis. Murmur plus fever is endocarditis. Exacerbation of COPD, I've mentioned amongst these. And the other important one is iatrogenic. People are given a non-steroidals for their arthritis, and the old-fashioned standard non-steroidals are very powerful sodium and water retention, and they block the action of ACE inhibitors. So that's a very common cause of inducing heart failure or making heart failure relapse. A number of arrhythmias, again, another one which is often more subtle is atrial flutter. 2-to-1 block, the heart rate's 150, you think it's just heart failure, the second P wave is not easy to see, but it's very easy treated. You just give them 25 joules, they go back into sinus rhythm. But if you don't spot the atrial flutter, they'll stay in heart failure and it'll be difficult to treat. So atrial flutter, if you've got a heart rate of 150 and it's not varying, always suspect atrial flutter. And thyroid disease, of course, usually these days blood's taken for thyroid, but thyroid toxicosis or hypothyroidism often can induce, particularly thyroid toxicosis, induce heart failure. And in the elderly, the classical thyroid signs are not very obvious. Okay, they don't always have the eye signs and the shakes and all that, or even the weight loss. T3 toxicosis, can be very... alcohol is another one, and drug abuse. Alcohol is widespread in some communities in the world, not this one, but in certain parts of Europe, people drink very heavily. And when I was in Oxford, we did quite a nice study. I was interested in the relationship because in Africa, I always suspected a lot of hypertensives go into heart failure because they drink a lot of home brew alcohol. We took spontaneous hypertensive rats, not a very nice study this, but we put spontaneously hypertensive rats, we fed them alcohol in their water. We put 5% or 10% or 15% in their water. And they drank that all day, and they were hypertensive. And and with LVH. And we then, after one period and then another, but then we kept it going actually for about 6 months. And they develop a cardiomyopathy. The blood pressure comes down and the heart dilates and the LV function goes right off. So that's chronic alcohol. A lot of people drink 10% of their water intake as alcohol. As I said, not here, but they do. If you go to Scotland or Sweden, particularly, maybe they drink a lot. So it's something which is in the background. And a lot of middle-class people drink a lot now. There's a big problem in the UK about actually middle-class people like doctors who like to have a bottle of wine every night. And it gradually, they get into the habit of having a bottle of wine every night, and they actually are drinking too much. So the middle-class alcoholic is a problem, because they won't tell you they're drinking. They just say, I just have a glass of wine every now and then. But actually they're having a bottle every night. So that if you've got hypertension and you're drinking alcohol like that, you may well develop heart failure. So acute pulmonary edema, I think everybody knows all this is kind of medical school stuff, okay, that the pressures go up, PA pressure goes up, etc. And but I just want to make the point, it's very complex, all this. That looks quite simple. But a lot of these things start in systole, even in HFnEF, as we discussed yesterday. There's delayed and reduced early diastolic filling. There's reduced RV systolic function and RV suction for the same reasons. So the return into the right ventricle is reduced. Atrial systolic function, atrial filling may be affected and reduced, as we know. The increased heart rate shortens diastasis, so reduces the time for filling of the heart. The pulmonary venous tone is very important, and we know that the sympathetic nervous system causes venous constriction, which will increase the pulmonary venous pressure. And I once had a patient who had a sympathectomy done on one side. For some reason, I forget now, I don't know, it was sweaty hands or something. Anyway, only worked on one side. The patient then got heart failure, and they had unilateral pulmonary edema. They had pulmonary edema in the lungs where the sympathetic nerves were working, but they didn't have it in the lungs where the sympathetic nerves had been cut. So that's an illustration of the importance of the sympathetic nervous system and the venous tone. And this is just illustrated about atrial function. We know it's impaired in these patients prior to admission to heart failure. And this is just a quick thing about congestion, because actually the main reason for admitting patients is congestion rather than low cardiac output. Patients complain of breathlessness or peripheral edema, but actually it's very difficult to actually quantify, because we just put our fingers on the legs and say, oh, there's a bit of edema or not. And it's also not done systematically before discharge. And I think, as a rule of thumb, you're probably all well aware of this, I always like to say, when the patient's sitting at 45 degrees, the JVP should be just visible above the clavicle. It should be you could just see it when they breathe in, okay? That's when they can go home. If the JVP is up halfway up their neck, or they've still got peripheral edema, they need more diuretics. Now, this is data I showed the other day, because I just wanted to illustrate the rapidity with which some of the things happen. So here we have people with systolic heart failure and diastolic heart failure, and you can see here this is the estimated pulmonary artery diastolic pressure, which corresponds to the left atrial pressure, really. You can see how it gradually comes up, but then shoots up towards the end. So there's something happening here. There's some kind of vicious cycle. Something's triggering, and then everything gets worse very quickly, and the patient goes into pulmonary edema very fast. So I think one of the things that's happening is, and this is not necessarily without an increase in body weight, and this is just skip this. I want to get on to the more interesting stuff. Now, this is interesting, because this is a recent paper, which I've always wondered about this. Again, years ago, we tried to look at venous tone in hypertension, but it was very difficult. But this is a very interesting study. It's an animal study. But they found that when they interrupted the normal arterial baroreflexes, and then they basically infused some fluid. And what they found was that here's the changes in left atrial pressure in response to infused volume when the baroreceptors were failing, were removed out of the system, and normal arterial baroreceptor function. And you can see that when the baroreceptors are removed, the pressure rises enormously, much higher than when the baroreceptors are working normally. Now, we know baroreceptor function is affected by hypertension. Arterial disease in the neck reduces baroreceptor function. That's been known for 20 years. The baroreceptor function is depressed in hypertensives. So what I think is happening here is, because the baroreceptors are not buffering the normal rise in pressure by dilating the veins remain very tight, so that pressure will rise much faster. The venous tone is much higher. And this may be part of the reason why this vicious cycle happens so quickly. The splanchnic volume, the volume of our blood is mainly in our veins. And it takes a very small change in venous tone to shift that blood out of the splanchnic reservoir into the IVC and into the cardiac circulation. And a bit of tightening can shift a lot of volume and very quickly put the patient into pulmonary edema. So it's something which we perhaps ought to think about treating somehow. I used to think nitrates would work quite well for dilating the veins, and they certainly do. And that may be one reason why nitrates do relieve symptoms, although there doesn't seem to be any evidence that nitrates actually affect mortality. So this is I'm going to skip all this, because I've seen this is all on the program for later. So I'm just going to skip all this. I just wanted this is the ESC guidelines, all right? Very difficult, very complicated. There's an organization in Britain called NICE, National Institute of Clinical Excellence, which tells doctors what they're allowed or not allowed to use. And they do a massive cost-effective analysis. Actually, it's a very, very good organization, and it stops a lot of waste of useless treatments. They've done one on acute heart failure, which has only just come out. They do a very, very thorough and nice analysis, and they basically just say, it's pretty straightforward, but the BNP is vital now. I think this is going to be talked about later in the next thing. But their guideline is very simple, and summary is basically there's no good evidence that anything works apart from diuretics. Ventilation does work in certain individuals. So I just want to skip one thing. I want to just skip all this. Yes, this is something you might be interested in, because this is good evidence to say that cardiologists have some value. We can add value to being other than a general physician. Okay, here's a standard management. This is what happens in many hospitals in the world. The patient with heart failure gets admitted into a general medical ward, especially if you're 80 years old and you come in with heart failure. You don't get the high-tech treatment. You don't get the Mayo Clinic treatment or the Brompton treatment. You get put in a general ward, and somebody comes around and gives you some intravenous furosemide, and then that's it. Okay. Now, if you've got standard management plus BNP, it's slightly better. At least you're getting the right treatment for the diagnosis. You've got heart failure. But if you've got a cardiologist plus BNP, you're much better off, okay? Your outcome is better, and it's very cost effective. More QALYs, what we call QALYs, so better value. So anyway, that's an introduction to acute heart failure. You'll hear more about management and treatment soon. So it's common. It causes a lot of burden on healthcare systems, particularly in high and middle-income countries. And these countries have got to cope with this double burden of communicable diseases and a rising tide of non-communicable diseases. So actually, it's tough. The commonest causes we know are ischemic heart disease and hypertension, but there are some little traps, don't miss. Cardiomyopathy, aortic stenosis, and constrictive pericarditis is another one that lurks around. The pathophysiology is complex, but I think that we ought to be thinking more about venous compliance and venous tone, as well as arterial tone, and not so much on the heart, perhaps. And patients with acute heart failure are better treated by specialists, which is nice to know. And this slide has been shown before. I often show this one when I'm teaching the medical students in Hong Kong to remind them of their history of China, 2600 BC. Well, I don't know what was happening in Britain, not much at that time, but they had doctors, right? And I think you all know this, right? Superior doctors prevent the disease, mediocre doctors treat the disease before evident, inferior doctors like me treat the full-blown disease, okay? So obviously prevention is better than treating too late. Okay, thank you very much.